All right, welcome to this explainer. Today we are taking a forensic deep dive into a truly landmark 2016 histological study out of the McGee Women's Research Institute. Now, for all the practicing gynecologists and PG students tuning in, we're looking specifically at the host response to synthetic mesh in women who are experiencing complications. Basically, we're taking those tough clinical realities you see in the examining room every single day, and we're putting them straight under the microscope to figure out the underlying cellular mechanics.
It's a reality many of you know all too well. Polypropylene mesh, which we use widely for pelvic organ prolapse and stress urinary incontinence, it honestly provides excellent anatomic and functional outcomes for the vast majority of our patients. But when complications do happen, they are absolutely devastating. You know the two most common ones: visible mesh erosion right through the vaginal epithelium and severe, debilitating pelvic pain. But here's the biological puzzle we need to solve. Why do some patients present with visible erosion, while others come in with severe pain, but their overlying tissue is perfectly intact? Like, what is actually happening at the cellular level that drives two drastically different clinical presentations from the exact same material?
Okay, let's dive into our roadmap for today. First, the clinical mesh dilemma. 2, macrophages, the cellular culprits. 3, the crime scene baseline. 4, path A, mechanism of exposure. 5, path B, mechanism of pain. And finally, some practical surgical takeaways.
Section 1. The clinical mesh dilemma.
So, we've known for a really long time, mostly from hernia repair data, that polypropylene meshes induce a prolonged inflammatory response right at the site of implantation. But for years, we were all kind of tempted to just take that abdominal data and extrapolate it down to the pelvic floor. The thing is, emerging evidence clearly shows the host response in the vagina is entirely distinct. To really wrap our heads around urogynecologic complications, researchers had to look specifically at X-sized mesh vagina complexes from patients who are actually experiencing these adverse events. And that's exactly what this study did. They compared 27 X-sized mesh vagina complexes from women with complications directly against 30 full-thickness vaginal biopsies from women without any mesh.
Section 2. Macrophages, the cellular culprits.
All right, for the PG students listening, here is a crisp, board-relevant review. Whenever a foreign body is introduced into the body, macrophages are the heavy hitters mediating that response. Conceptually, we can split them into two broad subtypes. You've got your M1 macrophages, identifiable by the CD86 surface marker. These are your classically activated pro-inflammatory cells. They secrete reactive oxygen species, and if they stick around too long, it leads to chronic inflammation and straight-up tissue destruction. On the flip side, we have M2 macrophages, marked by CD206. These are your pro-remodeling cells. Now, a little M2 activity is actually great for tissue integration, but excessive M2 activity, that leads to accelerated matrix deposition, resulting in intense fibrosis, shrinkage, and total encapsulation of the mesh. Keep those two in mind.
Section 3. The crime scene baseline.
Now, what's really interesting about this immunofluorescent labeling is how vividly it captures the cellular battleground. Notice those large, dark, circular voids marked with an asterisk? Those are the individual polypropylene mesh fibers themselves. And look at how every single fiber is completely surrounded by a dense, highly localized swarm of macrophages. Those are the red, orange, and green stains. The control tissue without mesh, it had virtually zero macrophages. But in these mesh explants, the inflammatory response is incredibly robust. It's fiercely localized exactly at the mesh tissue interface, and it's predominantly driven by that destructive M1 subtype we just talked about.
But here's where it gets wild: the timeline. The meshes in this study were explanted anywhere from 4.5 months to a staggering 93 months after the index surgery. Let that sink in. We are not looking at some acute postoperative healing phase here. We are looking at a persistent, chronic, highly active foreign body response that just keeps going for years and years after the patient has left your surgical care. The tissue is literally trapped in an endless loop of inflammation.
Section 4. Path A. Mechanism of exposure.
So the crucial point is this statistic right here. When the researchers compared the biochemical profiles of these explanted tissues, they found something huge. Mesh explants that were removed specifically because they eroded and caused exposure had an 88.4% higher level of an enzyme called pro-MMP9 compared to the meshes removed for pain.
Okay, so what does that mean? Well, MMP9 is a matrix metalloproteinase. It's a proteolytic enzyme, meaning its entire job is to break down tissue. When you see a massive, prolonged elevation of MMP9, it tells you there is a severe, destructive inflammatory response happening. The tissue matrix is actively being broken down. If you think back to that swarm of cells we just looked at, those M1 macrophages are secreting enzymes that literally chew up the structural proteins of the vagina, like collagen and elastin. This leads to a profound structural thinning of the vaginal wall, until eventually the underlying mesh erodes right through the epithelium. It's not a mechanical failure. It is a biological degradation process driven by localized immune hostility.
Section 5. Path B. Mechanism of pain.
Now, what about the patients with severe pain but no erosion? In those tissues, the researchers found a completely different correlation. Here, they saw a positive correlation between the percentage of M2 macrophages and interleukin-10, or IL-10. Remember, M2 macrophages are your pro-remodeling fibrotic cells, and IL-10 is a cytokine strongly tied to fibrosis. So because the polypropylene is a permanent foreign body that the immune system just can't degrade, this overzealous M2 response completely overcompensates, frantically trying to wall off the invader. And that drives massive, accelerated fibrillar matrix deposition.
And right here is the absolute core thesis of the study. We have one foreign material, but it triggers two distinctly different pathophysiological mechanisms that lead to clinical failure. In the exposure pathway, the immune system goes on the attack. M1 macrophages dominate, elevating MMP9, degrading and thinning the tissue until the mesh literally breaks through. But in the pain pathway, the immune system tries to entomb the mesh. M2 macrophages and IL-10 dominate, leading to extreme fibrosis and encapsulation. And here is the kicker. This thick fibrotic capsule causes the entire mesh complex to contract and shrink, sometimes by up to 50 to 70%. That dramatic shrinkage places immense, constant tension on the adjacent pelvic tissues and nerves, which presents clinically as severe, debilitating pain during palpation, ambulation, or intercourse.
Section 6. Surgical takeaways.
Now, the researchers did something totally fascinating to translate all this heavy histology back to the OR for us. Within individual patient samples, they compared the host response directly surrounding a single isolated mesh fiber against the response surrounding a mesh knot, which they defined as 3 or more fibers sitting immediately adjacent to each other. And wow, the results are striking. Simply having those fibers clustered together in a knot increased the total cell density by 1.23 times. It exactly doubled the destructive M1 macrophages, and it more than doubled the fibrotic M2 macrophages. The host response is highly localized, and it is directly proportional to the amount of material concentrated in one single area.
And this brilliantly illustrates exactly why your surgical technique and your material selection are just so paramount. To minimize this immune response, you absolutely must lay the mesh completely flat. Avoid folded mesh configurations at all costs, because a fold acts exactly like a knot. It multiplies the local material burden and skyrockets the inflammatory response. Minimize knots wherever surgically possible. Select wide pore meshes, ideally pores larger than 1 millimeter. Because if those fibers are too close together, those intense macrophage swarms around neighboring fibers actually overlap. This creates a continuous plane of scar tissue. We call it bridging fibrosis, which leads directly to the massive encapsulation, shrinkage, and pain we just talked about.
We'll wrap up on this thought. This study essentially proves that a persistent, destructive, and fibrotic immune response is to some extent a biological inevitability when placing polypropylene in the vagina. Sure, we can definitely mitigate it with pristine surgical technique, laying it perfectly flat, using wide pores, but we cannot eliminate the macrophage response entirely. So as clinicians dedicated to the pelvic floor, we really have to ask ourselves, is it time we start looking beyond current techniques and completely rethink the biomaterials we use in urogynecology altogether? It's a provocative question for sure, but one that this incredible histological evidence demands we consider. Thank you so much for joining me to unpack this essential research. Keep learning and keep looking closer.